All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more talk. Today we are going to talk about the p-values and the power and the statistics. This is especially for James Kelly, who had asked that when we, the non-medicals, when we are looking at studies, what is it that we should be careful for and how are these numbers working? So I wanted to give us a high-level introduction to the idea of the p-values, power, null hypothesis, and type 1 and type 2 errors. So let us start that discussion, and let's start from there. So 008 KLM says p-values. So yes, so these are the statistical data points that are used in studies to express how strong or not strong the study is. For example, if I go in here and if I go to this clinical trial, this is the ivermectin trial that we have discussed in the past. The idea today is not to talk about this trial, but to look at some of the data here and see how they have derived the p-values and what does that mean. So this is, remember, this is the study from Bangladesh, Dhaka Medical College, Dr. Raza Muhammad. So if you look at some of the data here, for example, there is this primary outcome, number of patients with early clinical improvement. And there is some data over here. And then over here is the p-value calculation. And you may have heard me say sometimes that if the p-value is greater than 0.05 or equal and greater than 0.05, then the study's data analysis or the outcome is not significant. So I want to discuss a little more about what does this really mean. So so Robert Adams says statistical analysis. This guy can do it all. I'll come back later. Thanks, Dr. Bean. You're very welcome. Okay. So, and Rob is a good friend of mine. So let's start our discussion here. First of all, the updates with the cool beans. The person who is 70 years old, he has recovered enough that I think we can stop reporting on him as well. Then there are two more patients who are a little more serious. There is one patient which I feel is the most serious so far that I have seen. And so she is in the corona ward. She has her oxygen saturation dropping occasionally down to 86, 84. Then it comes back. She is on high flow nasal oxygen as well. I believe 15 liters, so at the upper range. And the doctors are concerned. I have come in a little late and I have been helping. Please pray that she recovers. The labs, since we started administering ivermectin, it seems like that the labs are turning around. I hope that clinically she starts improving very soon as well and does not deteriorate any further. So with this, let's start a discussion about the p-values and power. So I'm going to draw a little normal curve over here. So let's say we are researching something. Let's say we are talking about ivermectin useful for the patient to reduce their hospitalization or not, or ivermectin useful to reduce the patient's stay at the hospital, or remdesivir useful for the stay at the hospital, some hypothesis. But what happens is the following. Let's say this is some sort of a data, and over here, let's say this is a normal chart, or this is a normal distribution of something, whatever it is, people's weight or blood pressures or their time in hospital or death rate, whatever that distribution may be. This is some standard normal distribution graph. When we pick up some data from this graph, that data is the sample from this population. The data here is called population. And when we take that data from here, that is a sample. Now imagine we have some sort of an intervention. What does that mean is that let's say we have a drug. let's say we have remdesivir or ivermectin or hydroxychloroquine, or we have vitamin D. We have something that we feel is going to be effective. And that feeling that we have is based on some test we have done or some literature we have seen or some mechanism that we saw. And based on that, we create a hypothesis and we say, you know what, I think that if we give ivermectin, there may be an improvement in the reduction in intensity of the disease, let's say COVID-19. Or there is a reduction in death rate if there is a particular vitamin D level that is observed. Some hypothesis is formed, and how is that hypothesis formed can be many ways. Again, as I said, there could be literature from the past that you look at, there can be mechanism of a drug that you look at, or there is some test that is done, and based on that test, you form further hypothesis. So now let's say this blue graph over here is a normal distribution without this drug. And then what happens is we introduce that drug to some folks, and the result is that the drug has its own effect. So the worst case will be that the effect, there is no real effect, and the drug and the non-drug population, the drug population meaning those who you are giving the medicine to, and the non-drug, the placebo group, for example, their results are really not different. The drug is not really as effective as we think it is. And again, when we form a hypothesis, at that time, we do not know that it will actually be proven that the drug is useful or disproven that the drug is not useful, and so on. So the two graphs that I'm making are just, I am explaining it. But when we start some study or research, we are actually unaware. So imagine if there is no difference in the people who are receiving the drug and the people who are not receiving the drug, then this is the kind of graph that we'll get. On the other hand, if let's say there is some difference, then what can happen is, so let's say I draw one more distribution, and let's say there is a lot of difference. And let's say the drug has created this kind of a result. And here, maybe this is the number of days in the hospital. And so without the drug, people are spending more time in hospital. And with the drug, they are spending less time in the hospital. That is probably the hypothesis. And from this data that I've made here, imagine that if that is actually true as well. Now, take one more case. So we have to keep these three cases in our mind when we are discussing this. One case is the first one that I showed, no difference between the drug and the placebo. Then this is another case where this is the placebo, the blue one, and the green one is the drug or intervention. Imagine we have one more case where we have data something like this, where the placebo, which is in blue, and the intervention, which is in red, are actually so closely together, they are distributed so closely together that there is actually a difference, but finding that difference may be very difficult, because when you take samples, when you do your experiments, there may be data that would actually appear to be overlapping, and there would be a lot of data that can overlap. And so in this area, when you look at all of this data, it will become very difficult to tell if that is a placebo effect or that is a drug effect. On the other hand, if we have this kind of a situation, then it would be very easy to tell if this is the drug or the placebo, because the samples are going to be so widely set apart that we can easily tell the difference. This idea is basically called the power of a study. The power of a study, if the standard distribution for the population and the drug's effect, they both are actually, there is no effect of the drug, then there is no question of the power, there is no power, there is no even a discussion of the power. On the other hand, if the normal distribution, let's say placebo group, and the drug or intervention group are very vastly separated, and we take samples and they're very different, then we say this is a study with very high power because the outcomes are really, really separated from each other. On the other hand, the problem becomes that when the non-drug or placebo distribution and the intervention or the drug distribution are really very, very much overlapping, then it becomes a problem to say that can we really tell? And in this kind of a study, the power becomes less. And I'm going to discuss these a little more, but I want to give this basic idea of what power is. And if this kind of a situation occurs, which many times does occur, then improving the power becomes an issue or becomes a problem to solve. And you can improve the power. One simple way is to actually increase the number of samples or use more participants. So with this general idea, let's start back here and look at this. So first of all, let's use ivermectin as our experiment today. And so we are sitting together, all the cool beans, doctors together. We have been hearing news from France and from Bangladesh and from other places. And we're saying, you know what? It seems like ivermectin is going to be very useful. And we form a hypothesis. And we say that maybe ivermectin can help reduce the number of days in the hospital. That is our hypothesis. The first thing to do now when we start a study is to create a null hypothesis. Null hypothesis is the opposite of what we are trying to prove. So null hypothesis will be, in most of the cases, we use the null hypothesis to say there will be no difference. We start from that point. So we all are discussing, we are saying that ivermectin would have some effect, but when we start the study, we start it this way. We say, all right, there is no difference. They both are the same. And then it becomes a responsibility to prove the difference. So saying that there is no difference between the new drug and placebo, for example, is called a null hypothesis. The hypothesis that we are forming to say we actually think there will be a difference when we will do all this study and collect the data, that is called alternate hypothesis. Good. So we've gotten a null hypothesis. Null hypothesis says no difference. Then the duty in the research is to figure out that can the null hypothesis be rejected, or will we fail to reject it? We never say that we accept the null hypothesis. We never say that we accept, this is not the term used. We don't say we accept the idea that there is no difference. We simply say, if there is no difference, we will say that we have not been able to reject the null hypothesis, or we have failed to reject the null hypothesis, and researchers, all of us, will become very sad. On the other hand, if we can prove with the data that this null hypothesis is not correct, then we can say we have successfully rejected the hypothesis. And how do researchers convey that message to you? They convey that message to you in 3-4 ways. They talk about the power of the study, they talk about the p-value of the study, and they talk about the confidence interval of the study. All of this, at least in medical field, has to be also combined with clinical benefit. There may be something that is statistically significant. For example, let's say I invent a drug today that I say will reduce the blood pressure by 1 millimeter of mercury. And I think you can already say that, wow, 1 millimeter of mercury reduction, we don't really need that kind of a drug, right? It is coming to your mind, correct? So let's say I come up with that drug, and I can actually do lots of experiments, and I can come back with the data, and I can prove statistically significantly that this happens with this drug. But which doctor is going to use 1 millimeter of mercury reduction in blood pressure? So clinically, this drug is of no use. So please remember, in case of medicine, we would always, and I'm sure that in other fields it's going to be the same, that the function plus the data, they both have to work. So in case of medicine, if something does not have clinical significance, then even if there is a difference statistically provided, and that is a significant difference, we would still not be able to use those kind of procedures or devices or drugs. So both clinical significance and statistical significance has to be done. This is why when you look at these studies, you would see that they would provide you clinical data to say, in our observation, the patient they recovered faster, or they had less intensity of the disease, or they went home quicker, or they did not die as often. So all of that is clinical. And then they would back it up with this statistical data and say, statistically, this is significant as well, what we're saying. Good. So once we have the hypothesis that there is no difference, then what is our job? Our job is to reject or fail to reject. If we fail to reject, we're sad. If we reject it, we are happy. Now, there is an idea of type 1 errors. Type 1 error, which you would actually see that in the studies nowadays, type 1 errors are more or possibly more. What does that mean? Type 1 error means that we have incorrectly rejected the null hypothesis. What does that mean? That the null hypothesis was actually present, meaning there was no difference, but we came back and we said, yes, there is a difference. For example, just to be candid, maybe hydroxychloroquine there is no difference, and we are just saying that there is a difference. If that is the case, then we would be committing a type 1 error. Or similarly, if we come back and we say ivermectin, there is actually, let's say, no difference, but we come back and we say there is a difference. So we have incorrectly rejected the null hypothesis that there is no difference, and that is called type 1 error. This error is also called alpha. Type 2 error is that incorrectly failed to reject that there was actually a difference, but in our data, in our sample size, in our study design, we didn't design it, or we didn't conduct it thoroughly enough to be able to actually fail to reject the null hypothesis and declare that the drug is useful. So we are not saying it is useful, we are just saying it is not useful while it was actually useful. Now, in those two errors, the type 2 error is called beta error as well. Type 1 error is more dangerous. Why? Or it is worse. Why? Because in type 1 error, we are rejecting the null hypothesis. We are saying there is a difference. The drug is actually working, but in reality, it does not. So that would cause harm. And one of the medical oaths, one part of the Hippocratical oath is that do no harm. So type 1 errors can result in outcomes or adapting of the devices, procedures, or drugs that might actually cause harm. So this is the null hypothesis and the errors. Now is the idea of the power. So I just discussed the power before. Once again, the power is the probability of actually finding a difference between the two things when that difference actually is present. So there is a drug, let's say ivermectin, and there is placebo, and there is actually a benefit of ivermectin, but somehow we have very low probability of finding it because maybe the number of people participating in the study are small, or maybe the effectivity is less, or maybe the distribution curves are overlapping too much. And even when the effect is present, we are failing to find it. That would mean low power study. And if a study has decided on such a drug or procedure or device or method where the outcomes are so far apart that it is so easy to find the samples that are different from each other, significantly different, then we'll say this is a study with a very high power. So back here, power, probability to find a difference if one exists. And believe it or not, sometimes it is very difficult to find a difference when it exists. And power can actually be, for medicos here, power can be calculated by 1 minus beta errors. Now, power depends on the sample size. You can increase power by increasing the sample size. You can increase power by increasing the difference between the two groups, as I just showed. You can increase power by increasing the results precision, so you analyze better, and you can increase power by reducing the standard deviation, and that is, you create more peaked distributions. Then comes the p-value. Now, p-value offers statistical significance in the research. It does not offer clinical significance. What does that mean? I can again make a drug that reduces the blood pressure by 1 millimeter of mercury, which is of no use, but I can prove it, let's say, significantly from data that it does do this. So my p-value will be very good, but still clinically that drug is of no use. So p-value only tells from a data point of view, from a statistical point of view, that there is a difference. And there is a significant difference. But the clinical difference may not be present. So now what is a p-value? P-value is the probability of obtaining a result like this one, assuming the null is true. What does that mean? What that means is, imagine we take ivermectin as an example. I am using ivermectin with my patients, and I say it is very effective. Maybe just the cohort of my patients, the group of my patients that I am treating, maybe they have lifestyle, or they have some geographical location, or they have some other habits, or some other foods, or some other reasons because of which they are actually handling COVID better. Right? So let's say that is the reason. But I am saying ivermectin does it. Correct? So now the question is, if I am saying ivermectin does it, what are the chances for this to randomly happen? Maybe it is actually doing better for my patients because of their lifestyle. So I have proved it, but what are the chances that this just happened randomly, out of the blue, without any reason, for other factors, not the drug itself? So p-value decides and shows that chance. For example, if a p-value is 0.05, which is used mostly in medical sciences, what that means is that the probability, the chance of creating this result that I just created randomly without actually the drug being functional and useful is 5%. That means if you keep repeating my protocol, out of 100 times you use that, 5% of the times this result would just occur without drug being useful. So the p-value is the probability of this result that is shown by some doctor or researchers just randomly. And if you want to be rigorous about it, you say, I want a p of 0.001. So 1 in 1,000 chance, or 0.0001, 1 in a 10,000 chance, or 0.000001, 1 in 100,000 chance. So the more you want to be stringent, the more you want to be careful, the more p-value of lower value you would like to have. So there's a question, James says, James Kelly, are there specific categories or participant numbers set in advance that impact p-values? Absolutely. So, excuse me. So James, there is when we design a study, at that time, we decide what kind of power do we want in the study and what kind of p-value will be acceptable. Standard is 0.5 or 5% probability of randomly finding the same results. That is standard. But you can actually decide that, hey, I don't want 5%, I want 10% probability, that's fine. And I want a power of 80% or power of 90% or power of 70%. So based on that, there are calculators available where you go and you plug in those numbers, and the calculator would come back and say, okay, for your study, you need so many people. Your sample size should be 500 people or 300 people or 1,000 people and so on. So yes, in the study design, you do it. If you read Dr. Zelenko's study, in the introduction part of the study, he discusses that I wanted an 85% power, or I believe 80% power, and an alpha, which alpha is the p-values cutoff threshold, an alpha of this percent. And because of that, the number of patients I needed were following. So James, yes, at the time of study design, you put these numbers that you are desiring to produce in a calculator, and it would come back and say, here is a sample size that you must have. And then if you show the results, these p-values can be satisfied if the null hypothesis is rejected. Good. So continuing on, probability of obtaining the results. Now, low p-value is a good thing. That means we are able to reject the null hypothesis because we are saying this kind of a result, if it randomly occurred, it would have occurred maybe 1 in 1,000th chance. So this is not a very big chance. This actually happened. On the other hand, a high p-value means that this result that just occurred, for this result to occur just randomly, there are more chances for that. And you would say, okay, this does not look good. In the medical literature, normally the researchers have figured out or agreed on 0.05 or 5% probability for p-value. It is arbitrary. It is a consensus in the researchers. And people actually deviate from that. And if they do deviate, they put that in their paper to say, my p-value is this, my power desire was this. Now, continuing on, usually 0.05 is the threshold. P-value should be lesser than alpha. What does that mean? Remember, we talked about it here, over here, incorrectly rejecting the null hypothesis when there is actually no difference. So here we are saying that, let's say we want this to be 5% only. That when we do our experiments, let's say we conduct 1,000 experiments with ivermectin. We only want 5% of the experiments to randomly give the incorrect rejection. But in the 95% of the cases, we want them to correctly identify if ivermectin works or not works. So that is a good p-value. So p-value is actually, the threshold is type 1 errors desire. And again, 5% is the desired threshold that we have kept. There are studies that keep it at 10%, or there are studies that keep it at 1%, and studies that are even lesser than that. Okay, so now let's use some examples, and then I would calculate an example with you as well for that Bangladesh study with ivermectin. So here, let's say we have a drug. Imagine this is remdesivir or hydroxychloroquine or ivermectin or vitamin D or something. And here is a placebo. And we are saying that we are going to create a study, and we did a study, and we saw how many people got cured of COVID-19 versus not cured. And again, there can be different kind of endpoints. You can say stay in the hospital, or the progression to severity of the disease, or the lab value of CRP changing, and so on. So here I've used a simple thing, cured versus non-cured. So let's say there is some drug here that 95, when given to 100 people, 95 got cured and 5 were not cured. On the other hand, in the placebo group, who were not given anything, or maybe cow milk or some placebo drug, 80 got cured and 20 were not cured. When you calculate the p-value, and I would show you the calculator in a second, the p-value is 0.001341. What that means is that the chance for this result to just randomly occur is about 1 in 1,000 or so. And we can reject the null hypothesis. We can say what we are saying, that there will be a difference. There is a difference. And we would adopt this drug and we'll use this drug. On the other hand, let's say there is another drug. And that drug, when given to COVID patients, 90 got cured, 10 were not cured, On the other hand, the placebo group, the control group, 83 got cured and 8 were not cured. And when you do the p-value calculation on this, the p-value comes to be 0.775 or even higher. And so that means this is not significant. It is greater than 0.05. Good? So John Sider says, my p-value is approaching significance. Very good. So we're almost done. So once again, at the last, clinical significance and statistical significance, they both have to matter for something to be adopted. So now the last part, I'm going to actually do a calculation, which I've already calculated and put the values in the calculator. So the p-value calculation can be done in many ways. For example, you can, let's say you have two groups of drugs, control group plus and the drug, and you have mean values of the result. You can compare the mean values, and that is called a T analysis. Or you can compare mean value plus standard deviation. If you have many groups, for example, you're giving ivermectin to one group, you're giving ivermectin to, let's say, 150 microgram per kilogram. To another group, you're giving ivermectin 200 microgram per kilogram. To another group, you're giving ivermectin 300 microgram per kilogram. Then there is a placebo group. Now you have 4 groups. So when you pull the data from them and you take their mean data and standard deviation, and when you calculate them together, that is called an ANOVA based calculation. I am using a third type, which is called chi-square calculation. And the way this calculation works is that you have 2 drugs. For example, here is the drug. Imagine this drug here is ivermectin. And then there is a placebo. And over here, you have various endpoints. So you're saying cured, not cured. And then you plug in the numbers and the calculator would tell you the p-value. So I'm going to do this in front of you with this in your presence with the Dhaka Medical College study. So here, if you look at it, this is the primary endpoint that they were working with. And the primary endpoint was number of patients with early clinical improvement. And there, the data that they're showing us is the following. 183 total patients that received ivermectin plus doxycycline, and 111 patients showed the endpoint that they were looking for. In the placebo group, there were 180 total patients, and 80 patients without any intervention showed early clinical improvement. Now, if we place that data here in this chi-square, so here, if you see ivermectin plus doxycycline, placebo, and then what we are doing is early clinical improvement versus not early clinical improvement. I called it late, but it should be called not early. So here, ivermectin, if I take this data, 111 people showed early improvement and 72 people did not show early improvement. In placebo group, 80 people showed early improvement just by themselves and 100 did not. So now if I want to calculate the p-value from this data, I'll say next. And if you see here, the calculator is asking what kind of significance I want. Do I want 5% probability of random error, or 0.1 or 1% probability, or 10% probability? So it is really studies design. So I'm going to use standard 5% probability, and I'm going to say calculate the chi-square. So here, if you see, it has done the calculation, and now it is telling us the chi-square statistics is 9. This, the p-value is 0.001983, significant. It is lesser than 0.05. Then they've done a Yates correction on that as well, and then even with that correction, it is 0.028, which is about 0.03, and that is also significant. So if you go back here to their data, you would see that they're saying p-value is lesser than 0.03, and of course that is significant. So this is how the p-value is calculated. So I would leave it here today. We would talk about confidence interval and how that is better than p-value, And how do we reject that data? What happens when it crosses unity? We would do that in another talk. So I hope this was not too dry, but I thought it was interesting for us to look at this as well. So there's a question, James says that normally in statistical math analysis, the bell curve typically has two standard deviations, above and below. Yes, worst case, best case. So my question is, biochemistry individuality must play a key role in outcomes. Absolutely. That is why we kind of do not look at those worst case and best cases. So my question is, must play a key role. Does standard deviation help or hinder or even count? So we use two standard deviation, that is why 95%, and we kind of leave the worst and best cases out. My thinking is, what if a blood thinner accidentally killed a person with G6PD? Yeah, so that is a situation where we say we do not want this kind of an outcome. And if that does happen, we would not just leave it out. We would actually go and research it. And this is what is called phase 4. If phase 1, 2, and 3 trial did not prove these things, there is called a phase 4 trial, which is when the drug is in production. You still continue to watch for that drug to make its effects and side effects. And you can then, based on that, pull the drug back as well and say, you know what, it is doing things that we did not want it to do. So of course, that is the most important part, that if somebody dies, then all the data is thrown out and you just stop that and say, why did this happen? So I hope that this made sense. And I hope that you enjoyed it as much as you enjoyed the other mechanisms and discussions. We will talk about the confidence interval at another time. Tomorrow, we'll talk about our open forum and have that discussion. So thank you very much. Please like, subscribe, and share. And if you wanted to support my work, there is a link in the description for support. And I would see you tomorrow.